So differences between heparin and warfarin, that's the video I'm going to talk about today. Kindly make sure you subscribe, it will cost you absolutely nothing. So differences between heparin and warfarin. So the origin of heparin, number one, you need to know that heparin is naturally found in our bodies, whereas warfarin is not found in our bodies. So in terms of origin, heparin comes from the basophils and the mast cells, whereas warfarin comes from the plant. And I said before, vivo and vitro. So in terms of heparin, it's endogenous and exogenous, whereas for warfarin is only exogenous. So the mode of action of heparin stimulates antithrombin 3. Antithrombin 3 later inactivates factor 10 and factor 2A, factor 10A and factor 2A most commonly. However, it can also inactivate factor 11, factor 9 and factor 12. Warfarin inhibits all vitamin K dependent because it's a vitamin K antagonist. It inhibits all vitamin K dependent coagulation factor. These ones you need to know them. Factor 2, factor 7, factor 9, and factor 10, and anticoagulant protein C and protein S. So the onset of action, that is for heparin, it's rapid onset of action, whereas for warfarin, it's slow. And the reason and this is the reason behind the bridging aspect. The bridging aspect literally says that when you have to administer warfarin as your anticoagulant, you have to give warfarin and heparin at the same time. So and then after a few days, then you drop the heparin, and through that you will have bridged the warfarin. So the duration of action for heparin it has a short half-life, whereas for warfarin it has a longer half-life. The site of administration for heparin is the blood. The site of action, sorry, the site of action for heparin is the blood, whereas the site of action for warfarin is the liver. The mode of administration for warfarin is IV or subcutaneous using syringes, whereas for warfarin is oral. So both drugs require monitoring. So for heparin, you monitor using APTT, but when you use low molecular weight heparin, you monitor using anti-XA, that is anti-10A. Whereas for warfarin, you monitor using PT or INR. And the most common ones we use is INR. What is the normal level of INR or the required, or what's the target when you're giving anticoagulant warfarin? 2 to 3. Whereas when you are giving the heparin, what's our target APTT? That in the comment below. Our antidote when giving heparin is protamine sulfate, and kindly note we have 3 types of heparin. We have low molecular weight heparin, we have unfractionated heparin, and we have synthetic heparinase. So in terms of the antidote or the reversal mechanism, we have partial reversal in low molecular weight heparin, and we have completely reversal in terms of unfractionated heparin. But the antidote is just protamine sulfate. Whereas for warfarin, we have 2, where you have the fast one and you have the slow one. So for the first one, you give FFP, or you give prothrombin complex concentrate. While it's slow, you give vitamin K, because you said warfarin is a vitamin K antagonist. The reason for giving us FFP and prothrombin complex is because it has these factors that we want. So it crosses placenta, while heparin does not cross placenta, and is the recommended drug to give in patients who comes with coagulation problems in pregnancy. So for example, VTE in pregnancy, we usually recommend heparin. Whereas warfarin is usually crosses placenta and predisposes the person to having fetal warfarin syndrome, which I have a video on that. In addition to that, it predisposes someone to having fetal bleeding. And as I said before, it is teratogenic. Thank you.